The next lecture which I'll be talking about is antipsychotic medications, also known as neuroleptics. Now, before we begin the lecture, what exactly is psychosis? Because the drugs which I'll be talking about are going to be antipsychotic. So it's always important to know what psychosis is. So psychosis is actually a distorted perception of reality. So you and I, we experience the world around us and we make meaning from the interaction between people. You see somebody walking down the street, you know somebody sitting next to you, you're able to visualize these things, right? So you have a sense of perception. But when this sense of perception gets distorted and you start to see things that are not there, or patients start to experience or hear things that are not there in reality, that is called distortion of reality, and that means become psychotic. Okay, this is called psychotic disorder. This is often characterized by delusions, which is like beliefs. They might believe that somebody's watching them, while they're in the room, or maybe the government is spying on them. They might believe the aliens are coming to invade the earth. These are delusional beliefs that are not actually factual or real. Or they might even have hallucinations, which either be auditory, like hearing voices that are not there, like sitting in a room and like, I hear somebody tell me I should go jump off the window. Well, nobody is hearing it. There's no radio playing, there's no TV playing. So that's a distortion of reality. That's called auditory hallucination, or even visual hallucinations, seeing things that are not there. If a patient is saying, I see people climbing on the walls, or I see aliens, landing on the top of my house. Well, you're like, I don't see any aliens on top of your house. Whatever you're seeing, they're not real. Those are known as visual hallucination, or even disorganized thinking. Okay, their thoughts are not coherent. They're saying things that are not real. That you ask them, what did you have for dinner, and they're like, the aliens are coming to my backyard. That doesn't make any sense. Okay, this is known as psychosis. Okay, and this is actually a serious medical conditions and a severe form of psychiatric illness that patients have to endure. So there are medications that we can use to treat this condition, and because the patients have psychosis, we're going to use antipsychotics. Now, the problem with patients that have psychosis is because they have too much dopamine in their brain. Remember, the brain is always trying to balance things. You have a balance between dopamine, acetylcholine, norepinephrine, serotonin. It's got to be a balance between all these neurotransmitters in the brain. So let's take a look at the brain here. And let's just go over some basic biochemistry. How is dopamine actually made? Well, dopamine starts with tyrosine, which is an amino acid, the L type. And the tyrosine is converted into dopa by the tyrosine hydroxylase. Now, dopa has to now be converted by dopa carboxylase into dopamine, and this dopamine is now made in the presynaptic neuron. Now, the dopamine is now going to be released into the synapse so it can bind to either the D1 dopamine type 1 receptor or D2 receptor. So there are D1 and D2 dopamine receptors. When there's too much dopamine, patients start to become psychotic, okay? And this is the beginning of psychosis. Now, the drugs which I'll be starting with and talking about are gonna be the neuroleptic drugs. And these are first, let's talk about the drug names. So the first drug you need to know for the board is haloperidol. And then we have the other drugs in the similar class that all end with the same last name, azines. Okay? So let me just write neuroleptics. So when you hear the word neuroleptics, it's the same thing as antipsychotics. So the other class of drugs ends with azines. So trifluoperazine, Let's use red. Pyrazine. Fluphenazine. Thorazine. Thioridazine. Chlorpromazine. So as you can see, they all end in the word azine, azine, trifluoperazine, fluphenazine, thioridazine, and chlorpromazine. Actually, it's the wrong spelling. So it's chlorpromazine. So the way I remember this for the boards is that I memorized haloperidol, which is very important, and every drug else that has the word azines at the end of it, that's how I recognize that is an antipsychotic. Now, there are high potency antipsychotics and there are low potency antipsychotics. And we're going to be talking about the high potency and which ones are low potent later on when we get to the side effects of this medication. But the mechanism of action of all these are known as the typical antipsychotics. They all block the D2, the dopamine 2 receptor. So what they do is the drug comes over here and blocks the D2 receptor so that there's no dopamine that can bind to the postsynaptic neuron. All these drugs are known as typical antipsychotics because we're going to be talking about also atypical antipsychotics, and I'm going to tell you what the difference between the two are. So mechanism of action, they block dopamine receptor. So what do we use antipsychotics for? Well, the first use is it's used to treat patients with schizophrenia. Schizophrenia. But we haven't talked about schizophrenia yet. So let's talk a little bit about what are the symptoms of schizophrenia. Well, patients that have schizophrenia has a chronic mental disorder. This is a very, very unfortunate conditions that patients develop. And they have periods of psychosis, okay? And also have this disturbed behavior and thoughts that they usually have. And then they have to start having a decline in function. And this is usually over 6 months. So patients with schizophrenia have psychosis. And remember, this is also due to increased dopaminergic levels inside the brain. So in order to actually diagnose a patient with schizophrenia, they must have 2 or more of the following, okay? They have something we call positive and negative symptoms. And I'm going to spend some time just showing you what are the positive symptoms of schizophrenia and the negative symptoms of schizophrenia. The positive symptoms, they have delusions, hallucinations, and the hallucinations is often auditory. Patients also have disorganized or catatonic behavior. And last but not the least, they have disorganized speech. or loose associations. So let's take a look at it. They have delusions. These are patients that they start to have beliefs that maybe somebody's trying to hunt them down. The government is looking into their records, okay? Maybe their neighbor is looking at them, but none of this is actually real. These are the delusions and the beliefs they have. They might have auditory hallucinations, which is they're hearing voices, okay? And also they can have disorganized or catatonic behavior. Their behavior is all disorganized, and also they have disorganized speech. Their speech is not coherent. They're saying one thing and they skip to another thing without ever completing their last thoughts, and they're kind of all over the place. You can't really have a fluent conversation with these patients because they have all this disorganized speech that doesn't really make a lot of sense. They have a lot of loose associations, okay? Normally when you talk to people, they are more coherent. They follow their organized thoughts and patterns, and their speech is normal. They may be talking really fast, and they have a lot of loose associations. These are known as positive symptoms of schizophrenia. Now, these patients also have negative symptoms, which include a flat affect. When you're talking to this patient, they're just looking at you like this. They have no facial expression. That is a negative symptom. Flat affect. They also have social withdrawals. They're withdrawn from society. Lack of motivation and lack of speech. Or thought. So when you talk to this patient, they have this flat affect. They are not smiling. They're not really showing you anything, just flat and mute. That's one negative sign. They're withdrawn from society. They're not really. These patients have lack of motivations. They're socially withdrawn from society, and they also have a lack of speech or thought. Now, these are known as the negative symptoms of schizophrenia, and the boards want you to know the difference between both. And there's a reason why they want you to know the positive symptoms and the negative symptoms, because the therapy that we use to treat these patients helps the positive symptoms more than the negative symptoms. That's the reason. So make sure you memorize these D's. I remember that there's the 3 D's, okay, or the 4 D's, okay, delusions, disorganized thoughts, disorganized speech, auditory. That's the last D part of the auditory that you can put in there as the 4 D's of positive symptoms of schizophrenia. Remember, in order to diagnose the patient, they must have at least 2 of the positive symptoms, so 2 out of 4 positive symptoms must be present in the patient. Okay? So, now, the drugs that we're talking about here, which is haloperidol or the other typical antipsychotics, helps the positive symptoms of schizophrenia. That's why I went through all this list, because the positive symptoms of schizophrenia, once a patient is started on haloperidol, they start to have less delusions. They tell you, oh, I don't hear the voices anymore because the drug is working. So that's why it's primarily used for the positive symptoms of schizophrenia. This drug is also used to treat psychosis, and acute mania, acute manic episodes, and Tourette syndrome. So these are all the disorders that you can use typical antipsychotics, to treat. Now, there are toxicities of these drugs, and the boards love to test toxicities of antipsychotics. One of the toxicities with this drug is they are highly lipid soluble. They love to deposit in the fat. So when they deposit in the fat, they're slowly released into the body. So a person that's overweight or obese that's taking an antipsychotic because either they have schizophrenia, psychosis, mania, or even Tourette's, when you take the medication, it's slowly released, and so it's gonna, because it's also stored in their lipids, it's also very slow to be removed from their body. So these drugs can be stored in the body for a very long time. Now, there are 4 major side effects you must know these major side effects, because the boards will, I promise you, test you on these side effects. And the side effects are: 1, extrapyramidal symptoms. So let's talk about toxicity. Extrapyramidal symptoms. We're going to talk about that. 2, anticholinergic symptoms. Alpha blockade. And 4, histamine effect. These are the 4 extrapyramidal side effects that the board loves to test. And we're going to go by each of them one by one. For extrapyramidal side effects of antipsychotics, the first symptoms, which usually happen in the first 4 hours of taking these medications, is acute dystonia. Acute dystonia is uncontrolled muscle spasm that patients develop, such as torticollis, which means their neck is in spasm and they can't really turn it back due to the side effect of the medications, or just severe muscle rigidity, or oculogyric crisis, which means their ciliary muscles are really contracted and their eyes, they can't really close their eyelid because their eyes is really popping out. Okay, that's an oculogyric crisis. So this is known as acute dystonia. Usually after 4 days, okay, patients can also develop akathisia. So this is within 4 hours. 4 days, they might start developing akathisia. Well, akathisia is also known as restless leg syndrome. Restless leg syndrome. Because these patients feels like their legs are constantly shaking, they can't stay still, they're constantly pacing back and forth because they can't sit down still. This is known as akathisia. This is a side effect of antipsychotic, and it's an extrapyramidal symptom. Also, about 4 weeks into taking the drug, they can develop bradykinesia. This is 4 weeks later, they can develop bradykinesia, which is a Parkinsonian syndrome, right? It's a Parkinsonian symptoms. Patients with Parkinson's have, problems maintaining their balance, right? They're slowly walking, shuffling gait, okay? Slow movement. That's where the word bradykinesia. So patients can develop these symptoms 4 weeks into using their antipsychotic. And the last but not the least, which is 4 months into using this drug, they can develop tardive dyskinesia. 4 months. Tardive dyskinesia. Now, tardive dyskinesia is usually involuntary movements, oral movements, like they're constantly sticking out their tongue like that, or they're having this biting and chewing of their tongue or tongue protrusions. They might have involuntary choreoathletic movements that's been observed in these patients. This is the last symptoms they can develop, which is a side effect of the medication. Unfortunately, we can reverse the akathisia, we can reverse the acute dystonia and akathisia, but unfortunately, once patients develop tardive dyskinesia, the symptoms are not reversible. So make sure you remember that, because this is the only extrapyramidal side effect that doesn't get reversed. Also, these patients can develop endocrine side effects, okay, which we're going to talk about later. as one of the other side effects, but let's go over the anticholinergic side effects. The anticholinergic side effects that these patients often develop are dry mouth, okay, because these drugs can block muscarinic receptors. They're muscarinic receptor blockers. So they develop dry mouth. They can have constipation, urinary retention. These are all side effects of anticholinergic side effects, okay? So when you block the muscarinic receptors, okay, normally, remember the parasympathetic nervous system is responsible for binding to the muscarinic receptors. When they bind, they cause you to produce saliva in your mouth. They cause your bowels to move. Remember, parasympathetic is rest and digest. But as soon as you block those receptors, the saliva cannot be made, so the patient starts to have dry mouth because they cannot digest their food very appropriately. They have constipation. They also get urinary retention because the detrusor muscle gets to relax instead of contracting, so they start to retain urine inside their bladder. Okay, so that's another side effect you must remember for the board. Also, they can block alpha-1 receptors. They cause alpha-1 blockade. Well, alpha-1 receptors are found on what? On blood vessels. So normally norepinephrine binds to these alpha-1 receptors. They cause vasoconstriction. They help you maintain your blood pressure. But when patients are on antipsychotics, once these alpha-1 receptors are blocked, they cause vasodilation of the blood vessels, so they develop hypotension. Hypotension. Their blood pressure can drop. It's another side effect you must know. The fourth side effect, they also have antihistamine side effect. They block histamine receptors. So when they block histamine, as an antihistamine, they can cause you to have sedation, right? Because, especially if you remember from our lecture from antihistamine, like diphenhydramine, one of the side effects is sedation. Well, this medication, because they block histamine, also they cause sedation. So you make sure you remember that. Now, the reason why I'm going to bring this up is very important is one day you're going to be on your wards and you're going to see a patient that has schizophrenia or psychotic patients, and the doctor's going to say, give them Haldol, which is the brand name for haloperidol. When you give the patient haloperidol, you're going to notice the patients calm down from their agitated psychotic state, and all of a sudden they calm down. Well, the reason why they're able to calm down is because of the histamine, the antihistamine effect of the medication, and they become sedated. And before you know it, the patient is sleeping and they pass out. Okay, so that's why we give haloperidol, or you can give these other medications for patients that are having psychotic or manic episodes. Now, they also have endocrine side effects because this drug, they are dopamine receptor blockers. Because they block dopamine, they cause hyperprolactinemia. Well, prolactin is often made in the brain, right? But dopamine is actually inhibits and prevents release of prolactin. So let's draw that on the board real quick. So normally prolactin is made by the anterior part of the pituitary gland. Okay? So the pituitary gland eventually secretes prolactin. Okay? Now, when prolactin is made, it's going to act on the mammary glands to make milk, right? Prolactin. However, prolactin is also inhibited by dopamine. That's how it's controlled. When you give a patient dopamine blockers, now you don't have any dopamine to inhibit prolactin anymore. Therefore, the amount of prolactin in the body is going to be elevated. So these patients can have stimulation of prolactin on their nipples and causing the patient to develop galactorrhea. Galactorrhea, which means if a patient is taking an antipsychotic and you start to notice this patient is producing milk without being pregnant or having a baby, that is the side effect of the medication because it causes hyperprolactinemia. So you can see the boards can test you in so many ways on this medication. This is why you must know all the side effects of antipsychotics from all the 4Ds, okay? Dystonia, akathisia, the bradykinesia, and the tardive dyskinesia. They're not 4Ds, I'm sorry. But these side effects that goes in series of 4, okay, 4 days, 4 hours, 4 days, 4 weeks, and 4 months. Very, very, very important. And also, if the patient's having dry mouth, constipation, urinary retention, it's because they can block muscarinic receptors. They can cause hypotension by blocking alpha-1 and also cause sedation from antihistamine side effect. And they can test you on hyperprolactinemia on the exam. So, now let's talk about which of these drugs actually are the high potency one and the low potency antipsychotics. The high potency ones are haloperidol. So what I'm going to do is I'm going to put them in red. Haloperidol, trifluoperazine, and fluphenazine. See, the first 3 drugs are known as high potency drugs. And the way you remember them is they are trying to fly high. Okay? So high potency. And the mnemonic is try to fly high. As you can see, trifluoperazine, fluphenazine, and haloperidol. Now, the reason why they call them high potency, very potent, is because they cause more extrapyramidal symptoms. So remember these extrapyramidal symptoms that I was telling you for the toxicity? These 3 drugs have high potency because they cause more of these side effects of dystonia, more likely develop tardive dyskinesia, akathisia, or bradykinesia. Now, the low potency medications are chlorpromazine, thioridazine. The last 2 are low potency, okay? Low potency, which means they cause less extrapyramidal side effects, but they cause more anticholinergic, alpha blockade, and antihistamine effects on the patient. That's why these are the low potency, because this high potency, as you can see, the side effects are pretty intense with the dystonia, the akathisia side effects. So usually the mnemonic to remember this is cheating thieves are low. Okay? For low potency, cheating thieves are low. So TH for the thioridazine and the CH for the chlorpromazine. Okay? So, another side effect you need to know about this low potency drugs with the chlorpromazine is chlorpromazine can cause corneal deposit. Okay? Can cause corneal deposits. So the way you remember that it has a C and it also starts with a C. That's why it causes That's how you remember it causes corneal deposit. And the thorazine, which is the thioridazine, can cause retinal deposit. Retinal deposit. With the T, to be able to keep in mind that at the back of the retina, where the image is formed in the eyes, thioridazine can cause deposits there. Okay? And haloperidol can cause tardive dyskinesia, which we already talked about. Now, the other drug toxicity they love to test you on, because these drugs, because they can write so many questions, is they can cause neuroleptic malignant syndrome. Neuroleptic malignant syndrome. So let's talk about NMS, because this will be tested on your exam, and you want to get every single baby points for antipsychotics. So what is neuroleptic malignant syndrome? This is a syndrome, like let's break the word into three, like we always do here. This is a side effect of this medication. So we have neuroleptic because it's an antipsychotic, so it's a drug malignant, it's always never good in medicine, syndrome. So it's a constellation of symptoms that patients develop while taking these medications, which include the following. They develop hyperpyrexia, which means high temperatures. Muscle rigidity, myoglobinuria, autonomic instability, and these are known as neuroleptic malignant syndrome. Okay, let's go over them. So they're going to give you a question on the boards about, let's pick a 25-year-old male with a history of psychosis. All right, they can even give you the symptoms of psychosis. They are delusional. They're believing they're like a god or something like that. They're like, that's manic episode, or they're just psychotic. They have hallucinations. They're hearing voices. Okay, and then they come into the emergency department with elevated temperature. Let's say the temperature is about 41 degrees centigrade. That's a high temperature, or a temperature of 104 degrees Fahrenheit. You're like, the patient has a fever. You're thinking, right? Yeah, fever. She's thinking maybe it's an infection. But wait a minute, they have muscle rigidity. So the muscle is in spasm. But then they can develop myoglobinuria, but they also have autonomic instability, which means they can be tachycardic, their heart rate is high. Okay, they can even be hypotensive, their blood pressure can be low, all right, because they have autonomic instability. But then they might give you a CK, creatinine kinase, maybe 50,000. Okay? These patients, if they have severe muscle rigidity and the muscle spasm is continuous, they can start to break down their muscles. And what happens is when muscles break down, they can start to release the myoglobin that's inside their muscles. Well, what happens when the myoglobin gets spilled into the bloodstream, it gets filtered by their kidneys. Well, myoglobin can be toxic to kidneys, okay? So that's not good, all right? It can cause acute tubular necrosis. But then the myoglobin ends up in the urine, and when you look at it, it's dark urine, like, wow, there's blood in this urine. But when you test it, it tests for blood, but there's no RBCs, right? Because there's blood there should be red blood cells, but what happens is there's no RBCs. That's usually classic because they have muscle breakdown. It's myoglobin, okay? It's the myoglobin in the muscles that's been broken down that's giving that red color to the urine, okay? So these patients have neuroleptic malignant syndrome. They have severe fever, and this has to be treated immediately because this is life-threatening, all right? So these patients must be treated with dantrolene, and the boards will test you on this. dantrolene, which is a dopamine antagonist. Okay, it's a dopamine agonist, because they're already taking a dopamine antagonist. What you want to do is give them dantrolene. So let's take dantrolene and put dantrolene here. So if dantrolene is a dopamine agonist, there's more dopamine now at the synaptic junction to compete with this antipsychotic, so you can kick it off by competitive inhibition and bind to these receptors. And that's how dantrolene works. You can also give the patient bromocriptine. Which is also another dopamine agonist. And the boards love to test you on NMS, and you do not want to get this wrong. Remember, this is different from serotonin syndrome. Remember, serotonin syndrome is from effects of serotonin SSRIs, okay, or patients that are on SSRIs that are taking MAOIs or TCAs. That's more serotonin. The problem in this case is these patients have severe side effects from antipsychotic medications, which is also known as neuroleptics. So the mnemonic to remember NMS, neuroleptic malignant syndrome, is fever. That's the mnemonic we use to remember it. So let's erase the board here. So the mnemonic is they develop fever. They do have a fever, which is true. They develop encephalopathy, okay, change in mental status. They also develop visual is unstable. So the vitals, their vitals is unstable vital signs. Remember, they can become tachycardic, hypotensive because of their autonomic instability. Also, these patients have elevated enzymes. And rigidity of their muscles. So that's the mnemonic to remember NMS. Okay? So this brings us to the end of typical antipsychotics. Now we're going to go ahead and talk about atypical antipsychotic medications.